Nikitha,
Yes, sir.
who's going to present this, you or?
Sir, me, I'll be presenting it, sir.
Yeah, start the thing, start the video and then.
Yes, sir.
So keep talking.
Yes, sir. So this is a
Obviously,
laparoscopic
this is.
cholecystectomy. It's directly
Yeah.
they're starting to show from the dissection of the fundus. If you can see, there was it looks
Not
like the
dissection,
dense. Sir.
dissection of the gallbladder. It's not just fundus. The fundus has been held up. So they are
Yes.
not dissecting at the fundus. They are dissecting initially at the callous triangle, dissection of the gallbladder, you should say. Okay,
Yes.
carry on. Yeah.
Dissection of the gallbladder. As we can see, there are dense additions of omentum to the gallbladder. They are trying to separate it.
See, he is using the, I think, he is starting to use the diathermy. I think maybe it's a bipolar. But initially he was using the suction apparatus, which is actually a good
Yes.
thing. I think you must have watched me and Niranjan and others do what is hydrodissection. Use the suction, keep washing in between, and use the water also to use it for dissection.
Yes, sir.
So see, this is a suction device, I think.
Then switches on to the diather.
Yeah, yeah. This is the, I think, ligation, if I'm right. I think this is ligation or bipolar, one of the two. See, this part of it, again, I'm bit, the thing is when everything is pulled up, it's a bit difficult to just, use the diathermy, straight away without actually knowing where you are. So he is now dissecting the momentum of the gallbladder.
Yes. This time again they are switched on to the suction using the hydrodissection.
Yeah, he's not using the hydro, he's just using suction.
Okay.
Niranjan sir has joined, sir.
Yeah. Good evening, Niranjan.
Good evening, sir.
So this is a difficult cholecystectomy. So basically now he is separating the momentum using a combination of suction and I think it's either bipolar or ligation device. So he is now straight away
Yes.
decided to go for the opening the gallbladder at I think it's a convenient distance. He is opening the gallbladder. Stop the video here, ma. Okay, let's first ask the students. Now, what are the options you have? It's obviously a difficult gallbladder. Obviously the callous triangle is kind of frozen. It is acutely inflamed gallbladder, very edematous and very inflamed. So, let us ask, let us say Praveen and Nikitha, what are your options here? We still have this one, what do you call, other part of the class. So do it quickly.
Yes, sir. Sir, the next best option would be subtotal cholecystectomy, like
Yeah.
dissection from the fundus first approach and en masse ligation at the callots if possible.
Yeah.
If you are unable to do even that, then the next option is conversion to open
Ah,
and doing a subtotal or total cholecystectomy depending upon the intra-op findings, sir, after converting to open. Feasibility.
okay. That's a reasonable answer. Praveen, what would you do? Now you are in this situation. You have basically you have dissected off the momentum. The gallbladder, as you can see, is still very inflamed and edematous. So what will you do? And callous triangle is not obvious.
Yes, same said by Nikita. I'll try first fundus first procedure.
Ah,
And if possible to identify callus triangle, if it is not possible, I'll try out the subtotal cholecystectomy. Sir. If subtotal cholecystectomy is not possible, then I'll try to convert into open and further proceed. Sir.
okay. Right. Tanya and Nitya, have you got any different opinion?
No, sir.
Same, sir.
I agree with them,
Same.
sir.
Niranjan, what will you do? This
I,
difficult
uh,
part.
I will still continue to dissect callots because the attempt which he has done is not adequate. He
Yeah.
has not even tried. He just did some blunt dissection and then this thing. What I will do is I will definitely try to decompress the gallbladder,
Ah,
make a puncture, suction out the gallbladder, and then I will try dissecting callots for some more time. If it is still not happening, I will cut it further down rather than cutting so high up, because the stone, if at all, the purpose of cutting the gallbladder open is to remove the stone which will be
stone.
eventually be impacted at the Hartmann's or the neck of the gallbladder or the cystic junction if it is a
Yeah.
Mirizi.
Yeah.
So cutting it so high up will probably not serve any purpose. It will not decompress the gallbladder completely if he is planning to do it for a stone.
Yeah.
But
Okay.
before
So
attempting that, I will do some more dissection.
yes. So, for the sake of the students here, see, Niranjan is in a very experienced laparoscopic surgeon, and I have to say, a very good laparoscopic surgeon. So, he will probably, putting his experience behind having done many of them, he will attempt to further dissection, to try and see if he can, find and expose the callous triangle and, the critical view of safety, which I think is reasonable for considering his experience. But I think all of you have answered correctly, and because you are likely to maybe damage something if you try to do that at early stage in your career. So what you answered is correct in terms of going for fundus first method. So dissect the fundus and gently dissect the gallbladder of the liver, and then see whether you will be able to expose the callous triangle that way. I think that would be a reasonable option. And other option is to open the gallbladder and decompress it and then remove the stone and then see if you can dissect it, because then you will get a better purchase. So those two options. Otherwise, if you can mobilize the gallbladder and if you still are not able to display the callous triangle and critical way of safety, then you are at liberty to do a subtotal cholecystectomy, but with the caveat that you are likely to leave a large chunk of the gallbladder. So, but you have to fulgurate the mucosa to ensure that it will not, one is further stone formation, and two, malignancy if this person is a younger patient. So, those two options, and failing all of these things, converting to open is also a very good option. So, all these three options are there. Now, let us just quickly watch what he is doing. Carry on. So, as Niranjan said, he's opened the gallbladder slightly higher up. So,
And remember, he has still not clipped the cystic artery. So, doing it with a monopolar will definitely cause too much of bleeding there.
Sir, he has not dissected the fundus alva, sir. Still the cystic plate is.
See, that's the thing, that is why we have put up this video for you to, analyze what you could have done and what, see, there is still visibility is poor because of the bleeding.
Yes, sir.
So before cutting the gallbladder, we have to have some idea about the anatomy. See, if the way he is cutting, still there can be a tenting of CBD which could have been there posteriorly or common
Yes.
hepatic duct. So before doing this, so you should be very sure about your anatomy.
Okay, sir.
See, this, here you're talking about Miritz syndrome. See, what if the CBD or CHD was stuck to the posterior wall there, causing the fistula, or at least, then, you are just going blindly, opening that posterior wall, which I think that is, this is one of the reason I wanted to show you the video. So basically now what he has done is he's now, virtually transected the gallbladder. See, when you have an inflamed situation like this, tissues can be drawn in. So there can be, important vessels and things which could be there while you are doing this. So you have to be extremely careful. So you would rather, get the gallbladder off the liver bed. In that case, unlikely that any structure would be stuck to this area because you are seeing the whole of the gallbladder. So this is a slightly dangerous move. He may be a very experienced surgeon, but the thing is, you have to always safety first. So here now he is trying to demonstrate the cystic duct stump, and he is fulgurating the gallbladder mucosa, and then suturing it. This one, the objections I have is he is left a fairly big chunk of gallbladder there, and he is also going to leave another big
Almost,
chunk of the gall.
almost 2/3 of the gallbladder is still there only.
No, and he is now going to take it off in the end, but leaving the posterior wall behind. So I think it is not necessary to leave so much of the gallbladder behind. So here onwards, he is just going to fulgurate it and suture the stump, and then remove the rest of the gallbladder, leaving the posterior wall behind. I think this, while this is an option which, for him as, somehow turned out well, there are a lot of steps which you may have to be more careful about, which is why I wanted you to see this video. Now he is suturing the thing. I think he is just trying to close the cystic duct stump. Again, this is a dangerous move
ಏನೋ
if at
ಒಂದು
all it's a
ಕ್ಲಾಸ್ ಇದೆ ಅದಕ್ಕೆ
Meniere's
ಅಟೆಂಡ್
syndrome.
ಮಾಡ್ತೀನಿ ನೋಡೇ ಇಲ್ಲ ನಾನು.
Who is talking? Who is talking? So this is also, see, we don't, do you know, any one of you know where the CBD or CHD is in this case? He's taking a deep bite, which could potentially, even close or take a part of the wall of the cystic CHD. So I think this is also, I wouldn't consider this, doing this as a, I don't understand why he is trying to do this. Niranjan? Hello?
Sir, and what
Sir,
exactly is the suturing, sir?
I think he's trying to close the mouth of the cystic duct.
that is what
But
he's trying to do a subtotal cholecystectomy. It's almost like only the 1/3 of the gallbladder is removed and just closing it off. He will definitely
see,
come back in a very short time with acute cholecystitis, calculus cholecystitis again. Because I don't think even we're not even sure whether he has milked out the entire gallbladder. Whether there is still a stone in the junction of cystic duct and CVD also, we are not sure.
I don't, he has removed one stone, but see this bite, that he is taking, see, we don't know, see, when everything is pulled up, you don't know where the junction of the cystic duct and the CBD, CHD is. So taking these deep bites, I'm not very comfortable with this. Niranjan?
Sir, hello.
He is taking very deep bites, I'm not comfortable because you don't know where the junction of the cystic duct and the CBD is. If this is a
Correct.
Mirizi syndrome, it
No,
could be
that is
well
what.
pulled.
So it is probably, as you said, it could be a Mirizi syndrome. So if it is Mirizi syndrome, I think preoperatively they would have done some investigations, and then they should have documented it, and then probably if it is Mirizi syndrome, preoperative ERCP and then surgery. And
Yeah.
if it is a Mirizi syndrome, you just have to open it up further down and probably expose the cystic duct and CBD junction, not the cystic duct, gallbladder CBD junction, and
Yeah.
probably you have to do a cholecystocholidocoplasty, where you
Ah.
close the gallbladder onto that hole.
Yeah.
So that is the recommended treatment. So here it's just probably trying to bail out. He's like just cut the this thing, removed the stone, and left the 2/3 of the gallbladder there. So this patient will definitely will come back with cholecystitis sooner rather than later.
So any questions on this?
Sir, exactly, sir. Here isn't he supposed to close the this
Correct.
end to this end, sir? Like,
Correct. He should have closed that, but he is closing the cystic duct. But his depth of the suture is so deep that I am not comfortable that he has not taken part of the CBD or CHD, because it is quite deep. The distance. Here, if the CBD is pulled up, you don't know. As you see, many times anatomy is so unclear. He sutured this, but we don't know the depth of the suture if the CBD or CHD is pulled up to the junction. Anyway, so now he is basically sutured this, and he is now going to remove the rest of the gallbladder, and again he is left the whole of um, the posterior wall of the gallbladder. So this is what he is doing. See, you can see, I don't see any reason why he can't take the entire gallbladder out. He is only taking the anterior wall, and then he is probably fulgurating the mucosa. I don't think it is with this inflammation. I think the gallbladder will come off the liver bed easily. So he's just taking part of the gallbladder, and I think he must be fulgurating the mucosa. Okay, I think we have got the gist of it. So basically, you would have done differently, as you all agreed that you would probably consider fundus first method. If you are experienced, then you can little bit more using hydrosuction and diathermy, bipolar diathermy. You can try to attempt to sort of the Callous triangle, and try to see if you can achieve the critical view of safety. Okay, so that is the gallbladder, that gallstone that he has taken out. Maybe there was only one stone, but anyway, so that is the thing. I think we'll have to see how this patient does in post-operative. We don't know, but certainly it's a video worth looking at, to look at some of the things that you would have done differently. Okay, now go to the next part of the thing.
sir, isn't the exposed mucosa we will be causing any problem, sir?
It will be. That is why leaving so much of gallbladder, posterior wall of the gallbladder, not necessary.
Okay.
Okay. Go to the next
Awesome.
part. Yeah. Okay. So this is the. So who will answer this? Let us go with Samir or Ainas, one of them.
So, um,
Ah,
like how to elicit Murphy's
Murphy.
sign.
Yeah.
So you ask the patient to be in supine position and
Ah,
with your flex knee. After that, you will start palpating towards the direction of the coastal margin, sir. And you
Yeah.
will ask you'll ask the patient to exhale, and then ask the patient to inspire. And when the patient is inspiring, at that if at that time during palpation, if the patient has a sudden sharp pain, then that is a positive Murphy's sign, sir.
Anybody wants to differ? Hello,
Sir,
Nikita.
actually,
Ah,
sir,
yes.
it, procedure is left hand should be on the right coastal margin, such that thumb will be at the fundus of gallbladder position, sir.
Ah,
So we have to keep pressure by the thumb. And when patients is ask the patient to take deep breath at the height of inspiration, when that gallbladder impinges the thumb, he has sudden sharp pain and catches breath, sir.
okay.
So then it is Murphy's post.
Nitya. Hello. Say something, Nitya. Not there?
Sir, I was talking in mute, I guess. Sir, correct, sir. Like, I would agree with what Praveen said, sir.
Okay. Tanya.
Yes, sir, I agree, sir.
Nikita,
Hello?
you agree with Praveen?
Yes, sir.
Okay. So that is the correct way of eliciting Murphy's sign. Now, what abdominal sign suggests chronic cholecystitis? Samir,
Hello. Yes, sir.
what abdominal signs suggest chronic cholecystitis?
Sir, mostly patients will have this dull lacking right upper abdominal pain with more aggravating on fatty food intake, sir.
Ah,
And
signs, abdominal signs, man. See, you have to understand the question. Anybody else? Ainas?
So that too, Nisa, like on deep palpation, they will have like there'll be a long-standing history of pain and like tenderness, sir, at that point. And apart from that, sir, if we consider chronic cholecystitis, that will more like the symptoms will be more common, sir, in comparison to eliciting signs, sir.
Correct. So that one first thing you have to say, there can be paucity of signs. There may be just palpable tenderness in the right upper quadrant. Gallbladder almost certainly will never be palpable because of the Courvoisier's law. When will you think patient with chronic cholecystitis may have palpable gallbladder?
So if it is obstructing the neck, sir,
What is that condition called?
Meares syndrome.
Meresis.
No, not
Mu-
Merit.
Mucosal gallbladder present.
Mucocele of the gallbladder, if that is part of the chronic cholecystitis, if the stone is impacted and there is mucus, the gallbladder is enlarged, then you may have a palpable gallbladder that constitutes mucocele of the gallbladder. So generally, there is, I don't know what was the purpose of asking this question, but it is generally lack of signs in patients with chronic cholecystitis unless it is complicated by an obstructive jaundice where the patient can have jaundice, or if the stone is impacted in the neck of the gallbladder causing a mucocele of the gallbladder. Tanya, Nitya, do you want to add anything to this?
No, sir, I agree. Usually it's only the scan that shows chronic cholecystitis. Patient will
So
have
usually chronic cholecystitis, the gallbladder shrinks and
yes,
what we
sir.
call as thimble gallbladder, just like thimble bladder, it can become a very shrunken, thickened, fibrosed gallbladder because of repeated attacks of inflammation. So you may not feel anything at all. Niranjan, anything to add?
Sir, nothing, sir.
Okay, so don't just because there is a question like that, you don't need to get flustered. Just think logically, and the answer is correct. What you said is right. Paucity of signs. There will be more symptoms, recurrent attacks of pain, but gallbladder not palpable. Okay, so what somebody, I think Likit state Courvoisier's law correctly. Do you know or you don't know? Likit, say something. Say hello. Is Likit there or not?
Sir, he's on call, sir. Probably
He's gone out. Okay.
receiving a call. Yes, sir.
So Ainas, define Courvoisier's law.
So, when a patient presenting with jaundice, sir, if
Yeah.
there is a like a palpable gallbladder, this is
Ah,
unlikely to be caused because of gallstones, sir.
correct. That is the thing. In a patient with obstructive jaundice, if the gallbladder is palpable, it is unlikely to be due to stones. So, what are the exceptions for Courvoisier's law?
Sir,
Double impacted. sir.
Stone.
exceptions would be double
No,
impacted stone, sir, CBD and cystic duct stone.
correct. One,
And
second
in
one.
case of empyema gallbladder,
Primary CBD stones
What?
and large primary CBD stones, sir,
Ah,
and a large stone at Hartmann spots of gallbladder.
have you heard of Clonosis sinensis?
Yes, sir. Parasitic infections of the
parasite.
gallbladder.
I think I don't know whether all others are all accepted. I think there are only two exceptions. One is double impaction. So you can address it many ways. You can say stone impacted in neck of large stone in the neck and all that. So if there is primary CBD stones, Praveen.
Yes, sir.
So if there are primary CBD stones, why should the gallbladder be enlarged?
So due to obstruction, sir, at CBD.
No, why? So CBD CBD is jam packed with stones, so the gallbladder is one dilated and enlarged.
Yes, sir.
Unlikely, usually that is not. Is that considered as one of the exceptions?
No, sir. Like only what
Same.
two exceptions that you said, that are the
Double
one that is
impaction.
given.
No, Praveen, then it has to be double impaction, one at the neck of gallbladder and then stone at the CBD.
Shown at the CBD. So the same thing. That's what I said. You are readdressing everything together. So the only two exception is one is this one double impaction, other is Clonosis sinensis. Okay, next slide. Nikita, what are the things in this? What is this and what is being shown in the picture?
It is an ultrasound image
Ah,
of the gallbladder.
ah,
First A is denoting the gallbladder, sir.
ah.
Whereas B is probably a stone due to the
No, probably a lie. It is a stone.
it is a
Because of
stone
what?
because of the shadow it made, sir.
What is it called?
Hypoechoic shadow.
Hmm, hmm.
Posterior acoustic shadowing.
Post acoustic shadowing. So, post acoustic shadowing. What else is seen? A, they have shown something.
A is the fundus of the gallbladder, sir, and
Ah,
this is the
ah.
liver. Superior to the
Correct.
gallbladder is the liver.
A is the wall of the gallbladder. What are
Wall
they
of the gall.
demonstrating?
Yes.
What are they demonstrating?
So
Is that
thickness of
normal
the
thickness? Yeah,
wall
it's
thickness
a
of the gallbladder.
thickened gallbladder. No, it is more than 4 millimeters. So it is thickened gallbladder wall. You see, have you got a pointer?
Yes, sir.
Yeah, come here, come more medial, laterally, more laterally. See there it is thickened. Come
Yes,
laterally here on this side.
significantly thickened.
Seek a significant thickening of the gallbladder.
Yes. There is a single
So,
stone in the gallbladder.
single stone which is giving rise to post-acoustic shadowing. So this is classical acute cholecystitis due to stone in the gallbladder. Doesn't seem to be impacted, but it is called acute cholecystitis. Okay, next.
So one question I want to ask
Yeah,
them.
yeah.
How would you differentiate a polyp and a gallbladder in a USG? One is acoustic shadowing. There is one more way in which
Yeah.
you can differentiate a gallbladder polyp from an stone.
I'll ask Ainas. Ainas, answer that question. Otherwise, Samir. Hello?
Polyps will be
Good.
fixed, sir. So mobility won't be like we can't elicit.
Correct. So if
Yeah.
you change the position of the patient, the gallbladder stone should move, but the polyp will not move. So mobility, as you said, gallbladder polyp is static. It is fixed.
Yes, sir.
Okay. Good question. Right. Next slide. Okay. Whom shall we ask? Is Likith back or not? Likith, are you back?
Mm. I don't think so, sir. I think.
Okay. Okay. Right. Samir, go for it. Symptomatic cholelithiasis. Counsel the patient for surgery.
Uh,
Quickly. Not much time.
uh, the first, I'll inform the patient that like if we don't go for surgery at this point of time, it can go into recurrent. Like patient will have recurrent biliary colic, recurrent episodes of pain. Further, it can go to like acute cholecystitis. They can land up in choledocholithiasis.
So
If
that comes later. Are you going to go straight for the reasons for I think you should first explain why and what you're doing. Then you should then tell them what are the complications. Then you should tell them what are the things that can happen if you don't get operated. You are going straight for the last bit of it. Okay, Ainas.
First we'll explain to them about their diagnosis, sir. Like they have cholelithiasis and it's symptomatic, sir. So that is one of the indications for them to undergo surgery, and
Yeah.
explain to them what the approach will be. That will be going ahead with a laparoscopic approach, and how exactly the procedure will be done, sir. And like what will be the expected outcome? Like we'll be removing the gallbladder, sir, and then in so that will like that's how we'll explain the necessity of the surgery. Then in we'll get all the routine investigations done.
No.
Yes, sir.
Wait.
Yes, sir.
So necessity of the surgery. His patient is got symptomatic also, that is recurrent attacks of pain and maybe vomiting, dyspepsia, and everything. So you say that all your symptoms are due to the presence of gallstones. It is causing problems. So that is why you need the surgery. So you said that. Then you should explain the surgery. The next question is pre-op preparation. Okay, right. So go to what are the pre-op preparation you will do?
So routine investigations, sir, including liver function tests, sir, like ultrasound and LFT will be the main ones. Apart from that, like PTINR, sir, uh, we'll be doing that. And after looking at the parameters, sir, then we'll go ahead with the surgery. And in terms of procedures, like it will be like we'll explain to them about uh, like the routines, we'll explain that there'll be a 4-port entry which will be there, sir, and it will involve removing the gallbladder after clipping the cystic duct and cystic artery, and the possible complications during the procedure, like
No,
chances
no,
of
wait.
Yes, sir.
Have you observed me or Niranjan or Muniredi sir? Muniredi sir doesn't talk much. Anyway, Niranjan and I would probably do the same thing. What is the thing I do first if once the patient is agreed for surgery?
So you diagrammatic representation, sir.
Yeah, diagrammatic representation. Yes, correct. And then what do I do?
Sir, you will say that you will give an injection and then we will
Correct.
anesthetize the
I
patient.
take the hand of the patient and show them their vein and say we'll put a cannula into it and we'll give you general anesthesia. You will not know anything. So you have to tell them
Yes.
that the surgery is going to be done under general anesthesia. You will not know anything about the surgery till you wake up. Okay, so that is very important.
Yes,
So
sir.
you have to tell them that the surgery is going to be done under general anesthesia, because if the patient has any major comorbidities which precludes administration of general anesthesia, such patients are contraindications for laparoscopic cholecystectomy, isn't it?
Yes, sir.
Okay,
Yes, sir.
so you have to advise them about the general anesthesia, and then you explain the procedure briefly, that you have put 4 ports and remove the gallbladder fully. You should tell them very clearly you are not just going to remove the stones, you are going to remove the gallbladder. So the patient asks you, why are you going to remove the gallbladder? Why don't you just remove the stones? So what will be the answer?
So high chances of recurrence. So like you can't just remove the stones, it
So
will.
what is the
And
explanation?
gallbladder, sir, and gallbladder is just a storage organ, sir, so it won't hamper the.
Yeah, that's fine. But
The
Nikita,
very
what is the
fact
correct
that
answer?
the stone itself is forming is because the gallbladder is
Disease.
defectively functioning. So
So,
that is why
what
we
is the
need to.
statement that is there? Gallbladder is removed not because it contains stones, but because
It
it forms
produces.
stones. Forms stones.
Stone.
So that is the answer. Okay, so you have to tell them we can't keep on going into your abdomen to remove gallbladder stones, because it will keep forming them. So the gallbladder is diseased and it is no longer functional. So it is better to remove it. So that is the answer. Okay,
And
so
also, if the complication of removing the stone versus removing the gallbladder, complication rates are extremely high for removing the stones
stones, correct.
because of bile leak, possibility of bile leak.
Okay, so what are the complications you are going to tell them?
Uh,
Let's ask Praveen. Praveen,
There might be chance of CBD injury and it may
not
cause
you
biling.
don't go directly to CBD injury. Man. There are a lot more things before. How frequent is CBD injury? Tell me, both in open and laparoscopic cholecystectomy. What is
5
the
to 10%.
frequency? Huh? My God, did I hear you right? 9 to 10%. If you have that kind of rate, you should. I would seriously advise you not to do any gallbladder surgery. Anyone? Can anyone give me correct figure of the CBD injury rate, both open and laparoscopic cholecystectomy?
The laparoscopy, it is
Less than 1%, sir.
That is
0.5.
a very poor answer. It may be correct, but it's a poor answer. You should know the exact rate, because it's such a common procedure. Which is higher, lap or open?
Opens.
Lap
Very
is
good.
high.
Lab is
Lap is
higher,
higher,
sir.
sir.
So 0.35 to 0.39% for open cholecystectomy, 0.39 to 0.45 to 0.48% for laparoscopic cholecystectomy. So it is less than half a percent. So if theoretically the legal rule book says any complication which is more than 1%, you are duty bound to tell the patient. So theoretically, you need not tell anything about bile duct injury, but the common sense says that you briefly mention it, because see, it is it's a the advantage, you have to not scare the patient away from you. Patient has come to you symptomatic gallstones, you want to operate. You are a surgeon, you want to operate on this patient, so don't scare them away. You have to mention other complications, and then, in passing, also mention bile duct injury. So, what are the complications? Now, I
Sir,
think Praveen has
in
lost his chance. So, I'll go to Nikita.
Sir, we'll start with the complications from the beginning of the surgery, sir. And anesthesia related complications,
Correct.
and then comes the port entry first beginning.
Yeah. So, what are the complications with entry
So
of port?
bleeding,
Bleeding.
bleeding would be the initial common in complication.
So,
The
how do you
second thing would be
avoid
the
that? How do you avoid it?
sir by a direct method pneumoperitoneum or Veris method pneumoperitoneum. With under vision, if we are putting the ports, we can avoid injuring the major. I mean veins,
No,
sir.
how
Visible
how
veins.
how does Niranjan and I, how do we do the thing for entry of ports?
Sir, infraumbilical Veris method pneumoperitoneum
Yeah, yeah.
through
After
the
that, you put the port, and then what do you do?
sir, and
You
then
shine
we
the you shine the
Entry
light,
scene.
no? You shine the
yes,
light
we shine the light and
and
visualize the veins.
ensure that there is no vessels where you are coming.
Yes,
So
sir.
that way, and then as soon as you put the second port, you put your camera into the first port and into the second port and visualize the port of entry, that is the umbilical area,
Umbilical port.
to
Yes, sir.
ensure that there is no bleeding from there.
Yes, sir.
Okay, so that is very important. Okay, so anesthetic complications, then entry
Port entry
complications,
bleeding complications.
bleeding, and then what else?
Then intraoperative dissection and
Now, you can also have either detected or undetected bowel injury, especially if its
yes, sir.
abdomen is distended and you are not careful. So you have to. So how do you avoid bowel injury?
But, sir, if in case of Veris method pneumoperitoneum, all the ports are visualized and in the distended abdomen we are putting. So if we are using a safety trocar for the first and the rest under visual, we can minimize the chances of bowel injury, sir.
Yeah, you have to, all ports are placed under direct vision, and careful screw cap method of entry into the abdomen.
With
The
Hodger.
other thing is, if patient has had previous tubectomy or any, see, if it's a big laparotomy or something, then we'll all obviously be careful. But the problem is people have tubectomies and things, and you ignore that. So when you enter through the umbilicus, there is a chance that you may hit a bowel. So you have to be careful in such situations. You put use the palmer's point, and then if at
After
the
dissection.
umbilicus, you may want to do an open method, or if you want to do, you can put a port in the palmer's
Palmer.
point only. Visualize the umbilical area, and then if that is clear, go for the umbilical port.
Yes, sir.
Most people, using the palmer's point, it may be a, usually you don't come across circumstances, but it is important to understand when we are faced with a problem, you have to know how to actually overcome those problems. Okay, so your entry bowel injury is another thing you have to be careful about. Then
Yes,
what
sir.
else? What are the other complications?
Sir, then during the dissection, the chances of bowel injury again, and also the chances of uh,
What
liver
bowel
injury.
injury? What bowel injury during dissection?
Sir,
Mainly.
colon, transverse
Colon,
colon
gateway,
injury,
colon,
duodenal injury.
duodenum.
Duodenum. Duodenum, especially if you don't recognize, because if it is a acute gallbladder or recurrent attacks, the duodenum may be pulled up and may be stuck to the gallbladder. So you have to be very careful. So what do you do in that situation? I will ask Sania. patient has, you think that the duodenum is stuck to the gallbladder. What do you do, ma?
Duodenum stuff. So we'll have to be careful in separating, sir.
Yeah, but how will you be careful?
Non-energy separation, sir.
Try and use don't use energy, use hydrodissection and that kind of thing. Hold on to the gallbladder and stick to the gallbladder. You don't mind perforating the gallbladder if usually you don't, but what happens is you will find the plane. Go to the gallbladder and start dissecting from the gallbladder. Don't dissect from bowel side, because there is potential for you to damage it. So then you will usually find a plane and use either hydrodissection and things like that, and gently, dissect off the duodenum from the gallbladder. So, you don't mind, even if a little bit of injury to to the gallbladder is not a problem, but ensure that you don't damage the so usually colon is non-recognition. If at all it's very inflamed and everything is stuck, sometimes even stomach can come and get stuck, but generally it is colon and the duodenum, but more commonly duodenum. So first thing is to recognize that if there is there is duodenum stuck to the gallbladder, so you have to be very careful. And there's some very rarely you have colon also stuck to it. Okay, so that bowel injury during dissection, right? After that,
Liver injury, sir. And
liver injury,
then comes the CBD injuries during the calloid dissection.
bleeding. Bleeding is the
Bleeding.
next common thing, because a very acutely inflamed gallbladder, you can have a lot of bleeding because you would not have got control of the cystic duct, cystic artery. So you can have bleeding, and sometimes non-recognition of the common hepatic or the right hepatic artery looping over the cystic duct junction with the CBD. What is that called? Moynihan's hump. So, Moynihan's hump. So you can have that. So without recognizing, if you can damage the right hepatic artery, occasionally common hepatic artery. So you can have torrential bleeding because of that. Very rarely, in very inflamed gallbladders and patients with portal hypertension, you can have lot of portal cavernoma, or even sometimes portal veins very adherent to the gallbladder. You have to be careful. So if at all patient has cirrhosis, you clever thing to do is to refer it to somebody else. If you have to do it, you have to be extremely careful. Portal cavernoma can be catastrophic. You can have catastrophic bleeding. Venous bleeding is much more difficult to stop compared to arterial bleeding. So you have to be extremely careful. So bleeding, then liver injury, you said bowel injury, and bile duct injury. So Nikita, what are the causes for bile duct injury?
Improper dissection of calloid triangle and not able to find the critical level of safety.
Non-recognition of the
Non-recognition of the
anatomy.
anatomy. Yes.
And wrong dissection, plane of dissection, as it happened in the last case. So non appreciation, or no, is one of the anatomy. Then what else?
In case of altered anatomy also, sir.
Correct.
Like
Anatomic variations. They are called anatomic variations.
anatomic variations.
Where you can have a non-existent or a very short cystic duct stump.
Cystic duct.
You can have a cystic duct which is running parallel to the CBD or CHD, and a low insertion of the cystic duct. So you think because it is inserting low, you think what you are clipping is the cystic duct, but you would be clipping the CBD or CBD usually. So low insertion, and sometimes you have multiple cystic ducts, and lots of variations in the anatomy. So you don't have to specifically see all of them. Variation in anatomy, non-recognition of anatomy. Then what else? Frozen callous triangle. Frozen callous triangle. See, even in a very simple case, you can have non-recognition of anatomy. as it happened in that last case. So that is why I am telling you that the most common things will be the frozen callous triangle. That is the commonest thing. Frozen callous, non-recognition of anatomy, variation anatomy. Then what else? Anybody else? Anybody? I always keep on telling. I think Nishwar Niranjan will also keep telling you guys. What? Excessive use of
Diathermy.
So excessive use of diathermy can cause immediate damage to the CBD, or if you have used a lot, it can cause stricture of the CBD at a later date. So that is another complication. CBD stricture. If you have not injured the CBD at that time, you can cause stricture of the CBD at a later date. Okay, and then liver injury, CBD injury, bowel injury, all of that you covered. Then post-op, what are the other complications you can have?
So, immediate post-op would be wound infections and
No, that is not immediate. It will be in the patient while in the ward. What can happen?
bile leak from the
Bile leak usually.
gallbladder fossa and bleeding.
Bile leak, bleeding. Yeah, secondary hemorrhage. You can have.
Yes.
You thought you would have stopped the bleeding, but bleeding can happen after that. Maybe that is why you have to ensure that the anesthetist, the blood pressure of the patient is good while you say that the bleeding has stopped. Because once the blood pressure comes up, once your pneumoperitoneum goes and everything, that tamponade effect is gone, and also IVC fills up and the blood pressure comes up, then the bleeding which you thought has stopped has not been actually stopped. So secondary hemorrhage while in the ward, that is another important thing. And of course anesthetic complications, aspiration, this one, and then all those things. Then bile leak, and usually if you have placed a drain, the bile leak can start even as early as the first post-operative day. Other situation is patient has been discharged and then patient comes back to you with what?
Port site infections and
Not port site infection. What is the signs? What are the signs of bile leak?
Pain, abdomen, jaundice.
Jaundice,
Pain abdomen,
distended abdomen.
jaundice. Pain abdomen,
Peritonitis
jaundice.
weakness also can
Fever,
happen.
fever.
Mm.
Fever with pain abdomen
Yes.
and jaundice and vomiting and loss of appetite and all. They're not actually feeling well, because usually I expect the patient to recover after laparoscopic cholecystectomy. So if the patient says, I'm not feeling well, you have to, the radar should go up and the antenna should go up and say, why is it happening? And examine the patient carefully, see if there is jaundice and then tachycardia and all those things. Then feel the abdomen, is the abdomen tender, get an ultrasound scan, and then you will see. So bile leak. And also you can have bile duct injury which presents at a later date because you've done something and the bile duct opens up and it can leak. And so bile duct injury can also on table recognition and also recognition in the post-operative phase. So these are the complications. Anything else to add?
Delayed complications also, sir.
What are the
Recurrent stones, remnant stones, and port
Yeah,
site hernias and infections.
correct. And then
And
another thing which
post-cholecystectomy syndrome.
another thing which I told you, retained stone, you said.
Remnant and retain. Recurrent.
Missed stones, retained
Missed.
stones, and secondary choledocholithiasis. That may not be complication, but it can be secondary to something else which I said. What is that?
Parasites.
Not parasite. Parasite, why should it is? What did I say when if you use excessive diathermy?
Stricture formation of the.
So if there is stricture formation, obviously there is stasis of bile, no, and that can cause secondary, some gallbladder, some CBD stones. If the stricture happens slowly, it would have given chance for the bile to become inspissated and form stones, no?
Yes, sir.
So slowly it can form stones. It can also present as obviously obstructive jaundice and pain, cholangitis, picture, fever with chills and rigors and all that. So I think we have covered all the complications. Recovery and follow-up. Ainas, what will you tell the patient about recovery and follow-up?
So the recovery is like for a very short period, sir. Like by like we are following the ERAS protocol, sir, so that patient can go back to his normal routine the next day, sir. And in terms of his diet and even the daily functioning, sir. At max, the recovery required is 1 day. And in terms of follow up, it will only be for the suture removal, sir, which we usually call after 5 to 7 days, sir.
Not just suture removal. You
And
just want
to see like how the patient is doing, like general follow up, sir. And apart from yes, sir, that's also me.
many of the complications can go unnoticed for the first 5 to 7 days. So when a patient comes to you, what are the things you look for?
Uh, like the general condition of the patient, sir.
Correct.
Then like any persisting complaints of abdominal distension or bloating.
Correct. So
Like
symptoms.
yes, sir.
Ask the patient specifically leading questions. Have you got any pain? Is the shoulder
Yes,
deep pain gone? Is
yes, sir.
there nausea, vomiting, appetite, sleep? As you said, pain, fever, all of these things. So all of these things will tell you if the patient has got no symptoms, then you're very happy. Patient is doing well. So if he has any symptoms, then obviously you are looking for what are the reasons why he has got these symptoms, he or she has got symptoms. So then what will you look for?
So we will look at icterus, sir. Like if the patient is
Correct.
icteric,
Stress. Then
uh, then the again like if he's complaining of abdominal distension or if there is severe tenderness at the operated site, sir, then that is also one of the signs, sir, which we'll consider.
look for pallor.
Pallor, yes, sir. We'll look for pallor as well, sir.
So bleeding can
But
happen slowly, no?
yes, sir.
Patient can
But
have uh,
like till 7 days, will it manifest
we
after
are
such a prolonged
no we
period,
are
sir?
that's why I said recovery and follow. So nobody said 7 days only. You said
Yes,
seven
sir.
days. We'll call the patient.
Yes, sir.
But
Yes, sir.
when the patient comes to you, whatever time the patient comes to you, he may come
Yes, sir.
on third day or second day because he's not feeling well. You have to look for pallor because bleeding, ongoing, it may
Because there is
not be
something
bleeding
called a secondary hemorrhage, which can happen after 48 hours also.
also. Yeah.
If
Patient
patient
would
is
have
on blood
gone.
thinner, there will be oozing, and you would have kept a drain, nothing would have been there, and you remove it, and then he can start oozing. Or if the BP shoots up and he's on blood thinners,
So bleeding,
or the
pallor,
sloughing out of
interest,
the cystic artery or something,
correct.
where you're clipped.
Slipping, if you have not applied the clip properly, it can slip and that can cause bleeding. So the bleeding is a definite thing you have to look for. So fever, so pallor, icterus, and you see if the patient has got any temperature, and then look at the abdomen. Is it soft, distended? We look at the wounds and site. Is it clean? Is there any evidence of wound infection? And is the abdomen soft and non-tender? So all these things you see. And if all these things are clear, you obviously remove the sutures and say goodbye to the patient. So all of these things you have to be careful. Gallbladder is still a very critical operation because it's the commonest operation we do and still the most litigious operation. So you have to be extremely careful. All these things has to be checked every time. Okay. What is the time now?
10 o'clock.
10 o'clock. Yeah. Have you got any more slides?
Sir, there are 4 more questions, sir. So we'll
Move to the next slide. What it is, we'll see.
about the instrument
Uh,
and about the post-op, all the things,
Yeah.
sir. So
Okay.
we'll use in the next OSCE class, sir.
No, you show the instrument.
Yes.
Ah. Samir, tell us, what is this?
The laparoscopic clip applicator.
That I think anyone would say, but you have to specifically say what it is. Looking at the size. Huh? What is that, man? Nikita?
Sir, it's a laparoscopic gallbladder clip applicator, sir.
No, not necessarily. You can use for other things also. But what is most striking in that clip applicator? See, this is where observation power comes in. Anyone? Pointer is there correctly. Anyone?
So the
See, this, have you not seen a regular clip applicator?
yes, sir.
This is a 5 mm clip applicator, right?
Yes, sir.
Is that what you were supposed to say? Because the
By the
usual
color.
clip applicator is much bigger, 10 mm one. So what is striking about this is a 5 mm clip applicator. So what material, Ainas, what material is the clip?
Sir, titanium clips are used, sir.
Okay, what are the complications of the clip?
Sir, like rarely the clip could slip, sir. Which could
Slippage, yes, slip,
uh,
it can slip, yeah.
then rarely it can cause a foreign body reaction, sir. Like a like localized inflammation or like granuloma formation, sir. Right, sir, right?
Titanium is generally very inert material, so I don't think that will cause that. So
Liga clips
slippage,
or Liga clip or Hemolock? Which one is this?
So this is Liga clip, sir.
Is it metal or plastic?
So Hemolock is what appears to be. Hemolock is
It
plastic.
looks like a Hemolock clip. Even if you look at the tip of the clip applicator, see there is a jaw there.
Yes, sir. Yes, sir. It is plastic, sir.
And it is
Yes.
a 5 mm, 5 millimeter.
Yeah.
You have seen us using that also.
Yeah.
So this is made of a polymer.
Yeah.
Mm.
That is why I asked you that question, and I think okay. So by and large, I think clip applicator erosion can happen with the metal clip. Erosion into vital structures can happen rarely, and slippage of the clip. Any other complications? Anybody? Niranjan, ಅಷ್ಟೇ ಅಲ್ವಾ? Anything? Niranjan?
Sir, sir, nothing else.
Okay, right. Next slide.
Nothing else, sir.
Next slide. No, no, go to that
Only thing
previous.
is they might ask you which one is more secure. Only one difference, which one is more secure?
Which is more secure? Nitya?
Hemolock is more secure.
More secure, sir, because it has that lock.
Locking
Yeah.
mechanism.
Locking
Yeah.
mechanism. Okay.
So that you should be knowing. Okay. They may ask you different colors there. What are the colors? If somebody knows.
Blue, white, green, and yellow. The most common one which we use is
No,
green,
no,
sir.
no. That is metallic clips, Liga clips.
Hemolock.
Okay.
Hemolock, sir.
Okay. Tell the green. What is it number? What is the number? Green is
Is
what
number
number?
3, sir. Number
Huh?
3, sir.
Please.
There is nothing like 300,
Yes, sir. Okay. 100, 200, 300, and
300, 400.
yes, sir.
Yeah, no 600. Okay.
Mm.
So,
And the
yeah,
green color and the purple color, all those are for hemolock clips. That you should be knowing. Somebody who is good with laparoscopy, if he is bored, will ask you all these questions in the Viva or in OSCEs also.
Okay, so now one more question. Nitya,
Yes, sir.
if you are asking for a large clip, what should you be worried about?
We should be worried whether we're actually clipping the cystic duct or CBD. The moment we should have a doubt that are we
Correct.
really clipping the cystic
Whenever
duct?
the duct is very large and you are asking for a large clip, think twice. Ask for somebody else to come and confirm what you are clipping is actually indeed cystic duct and not the CBD or CSD. Okay, so that is the importance of this. Okay.
Also, just because they've kept a yellow clip, please never use it for a artery until and unless it's a very big one. Okay, they will say, sir, green khali agide, use yellow clip, it is big. So what will happen if you use that yellow clip for cystic artery?
There won't be a proper approximation, sir. Like it will be excess, that gap will be there and can go and hinge on to adjacent structures also. Like it
Not only hinge
adjacent.
on to adjacent structures, it will slip out
Slip off
Like,
because of pulsations.
because the
so,
diameter of the artery is a very small one and compression will not be there. That is when the, as sir was mentioning, there can be bleeding. So never make that mistakes. People will say, sisters will say, sir, ಕಾಲಿಗೆ ಆಗಿದೆ ಇದು ಯೂಸ್ ಮಾಡಬೇಡಿ ದೊಡ್ಡದು ದೊಡ್ಡದು ಅಂತ. It is more secure ಅಂತ. That misconception will be there. So never do that mistake, especially for a artery, even for a cystic duct also. Use it only when you are absolutely sure, as sir was mentioning. Think twice whenever you ask for a bigger clip that it is not CBD. Make sure it is not CBD and then only use this. And preferably, if you have to use a bigger clip, it is better you use a suture, either extracorporeal knot or a endoloop kind of a thing, rather than using a broad clip.
okay. So I think we'll stop here. Because it was this, lent itself nicely to the thing. So we come to this clip business. So we finished now. So okay, now comments and then comments and questions.
So, no questions so far, sir, but the class was engaging, sir, today regarding the case operative discussion as well as the OSCE. Everything was detailed, and though the questions I put up was very superficial, the discussion happened very deep, sir.
Right? Anybody else? Questions, comments?
Sir, it was an interesting class, like very engaging, as Nikita said, sir. We should do this more often, like a operative video followed by an OSCE.
Yeah. Okay. Good. Niranjan, final comments.
Good discussion, sir.
Okay. So I think basically showing these things as live the videos where the things are things are happening, it will probably more realistic and it will bring you more closer to the real life. So for you to make decisions on the table, stopping the video and saying what are you going to do. I think it will make it more practical for you to on table quick decision making or asking for help. All these things you can you do. So that is why live videos um, is actually very useful. Okay, so I think all of you did well. So if there are no further questions, we'll close the class. Thank you. Good night.
Good
Good
night,
night,
sir.
Good
everybody.
night.
Thank you, sir.
Niranjan, thank you.